Lecture 7. Dear students, in the last lecture we were studying the physiological characteristics and features of hypothyroidism, and we studied that in adults hypothyroidism in severe cases may lead to the development of an edematous appearance throughout the body called mixed edema. Mixed edema develops in persons who have almost a total lack of thyroid hormone function. These patients may have bagginess under the eyes and swelling of the face. In myxedema, there are increased quantities of hyaluronic acid and chondroitin sulfate present, which are bound with proteins to form excessive tissue gel in the interstitial spaces, which causes the total quantity of interstitial fluid to increase. Now, because of the gel nature of the excess fluid, it is immobile, and therefore the edema is of non-pitting type. Cretinism is a condition which is because of hypothyroidism, but this occurs in infants. Cretinism is caused by extreme hypothyroidism during fetal life, infancy, or childhood. It may result from congenital lack of a thyroid gland called congenital cretinism, or it may result from failure of the thyroid gland to produce thyroid hormone because of a genetic defect of the gland, or it may result because of the lack of iodine in the diet, which is known as endemic cretinism. Now, this condition is characterized by failure of body growth and by mental retardation. Mental growth is affected because of the retardation of the growth, branching, and myelination of neurons of the central nervous system. Now, in these infants, the skeletal growth is more inhibited than the soft tissue growth. Now, as a result of this disproportionate rate of growth, the soft tissues are likely to enlarge more than the skeletal tissues, giving the child with cretinism a short, obese, and stocky appearance. A short, obese, and stocky appearance. Now, in some cases, the tongue may become so large in relation to the oral mucosa that it may obstruct swallowing or breathing, and therefore producing a characteristic breathing sound in these patients. The treatment of cretinism is to give oral thyroxine as early as possible. Now let's have a review of the thyroid function tests, because these tests are helpful in diagnosing different thyroid disorders. Serum TSH levels. Serum TSH levels are decreased in thyrotoxic states, hypothyroidism of hypothalamic origin, hypothyroidism of pituitary origin. And serum TSH levels are increased in hypothyroidism of thyroid origin. In addition, serum total and free T3 level and serum total and free T4 levels, their concentrations may be measured in blood, and their values are increased in hyperthyroidism and decreased in hypothyroidism. We can have direct tests of thyroid function, such as radioactive iodine uptake test. This has raised values in hyperthyroidism and decreased in hypothyroidism. Then there are miscellaneous tests, like tests to detect antibodies against peroxidase enzyme and thyroglobulin, antibodies against TSH receptors and T3 and T4. Serum thyroglobulin may also be measured. And in case of nodules or swelling in the thyroid gland, fine needle aspiration cytology is done to study the type of cells in the under the microscopic vision. Next, we start the study of the adrenal gland. Adrenal gland is present over the upper poles, on the upper poles of the both kidneys, and therefore that's why it is known as adrenal gland. Basically, there are two endocrine organs in the adrenal gland, one surrounding the other. The innermost is the adrenal medulla, and the outer gland is known as adrenal cortex. We will first study the adrenal cortex. You can see in this figure a cross section of adrenal gland showing the brown part or layers of the adrenal cortex, while the adrenal medulla is shown in bluish color. The adrenal cortex. adrenal cortex tissue is composed of three relatively distinct layers. These layers are known as the Zona Glomerulosa, the Zona Fasciculata, and the Zona Reticularis. Now, there are two major types of adrenal cortical hormones which are secreted by the adrenal cortex. They are known as the mineralocorticoids and the glucocorticoids. The mineralocorticoids are named because they especially affect the electrolytes, that is the minerals of the extracellular fluid, especially sodium and potassium. And the glucocorticoids are called glucocorticoids because they have important effects that increase blood glucose concentration. The adrenal cortex layers, you can see in this figure, the zona glomerulosa is a thin layer of cells that lie just under the capsule, and it constitutes about 15% of the adrenal cortex. Now the cells in this layer are the only cells that can produce aldosterone, which is the main mineralocorticoid hormone. The secretion of these cells of zona glomerulosa is controlled by angiotensin II and potassium. So angiotensin II and potassium both increase the secretion of this aldosterone. The second layer is the zona fasciculata. This layer constitutes about 75% of the adrenal cortex, and the cells secrete the glucocorticoids. And among glucocorticoids, the main hormones are cortisol and corticosterone. Now remember, the secretion of these cells is controlled by adrenocorticotropic hormone or corticotropin, which is produced by the anterior pituitary gland. The third layer, the zona reticularis, is the deepest layer of the cortex. It secretes the adrenal androgens, and the adrenal androgens are dehydroepiandrosterone and androstenedione. In addition to these adrenal androgens, the zona reticularis also produces small amounts of estrogens. Synthesis of adrenocortical hormones. All human steroid hormones are synthesized from cholesterol. Although the cells of the adrenal cortex can synthesize small amounts of cholesterol themselves, but about 80% of the cholesterol used for steroid synthesis is provided by low density lipoproteins in the circulating plasma. So the low density lipoproteins, they attach to specific receptors on the adrenocortical cell membranes, and these are then internalized by endocytosis, forming vesicles which fuse with cell lysosomes and release cholesterol, which is used to synthesize these steroid hormones. Now, once the cholesterol is released in the cell cytoplasm, it enters the mitochondria, where it is cleaved by the enzyme cholesterol desmolase to form pregnenolone. Now, pregnenolone is the main molecule from all the adrenocortical hormones are produced. Now, in all three zones of the adrenal cortex, this first step in steroid synthesis is stimulated by different factors. For example, ACTH and angiotensin II increase the conversion of cholesterol to pregnenolone, while in the synthesis of glucocorticoids, it is the ACTH that stimulates it. Mineralocorticoids. The main mineralocorticoids are aldosterone, which is very potent and accounts for about 90% of the mineralocorticoid activity. Then there is deoxycorticosterone and 9-alpha-fluorocortisol, which is synthetic compound. Now let's study the main mineralocorticoid, which is aldosterone. In this figure, you can see the steps of the production of aldosterone from cholesterol. So cholesterol is changed to pregnenolone, then progesterone, then deoxycorticosterone, and finally to the aldosterone. So 60% of circulating aldosterone combines with the plasma proteins, and the rest is in the free form. So as a result, aldosterone has a relatively short half-life of about 20 minutes. The normal concentration of aldosterone is 6 nanograms per 100 ml, and the excretory rate is 150 micrograms per day. The actions of the aldosterone Firstly, we'll discuss the renal and circulatory effects of aldosterone. Aldosterone increases reabsorption of sodium and excretion of potassium by the renal tubular epithelial cells, especially in the principal cells of the collecting tubules and distal tubules and collecting ducts. So this is the main important effect of the aldosterone. Now, although aldosterone has a potent effect to decrease the rate of sodium excretion by the kidneys, the concentration of sodium rises only very little. The reason is that while the sodium is being reabsorbed by the tubules, there is simultaneous osmotic absorption of equivalent amounts of water. So, therefore, the overall plasma sodium concentration remains the same. So I stop here for today's lecture. The assignment for today's lecture includes the question: give pathophysiology and features of an infant who is diagnosed as a case of cretinism. And MCQ: the serum TSH levels are increased in which of the following option? MCQ 2: which of the following hormones is not synthesized in zona fasciculata?